Geriatric Grand Rounds, everybody. Few announcements before we get started with today's presentation. Next Grand Rounds is going to be December 2nd, and that's going to be led by Dr. Nicole Rothman, and she's going to be given an update on osteoporosis treatments. Next Journal Club will be December 9th, and that will be led by Lauren Cohen, one of our psychology interns, and Dr. Jeff Wallace. Other announcements, following Grand Rounds today, please look out for an email with a link to an online evaluation. We'd really appreciate it if you could take a few minutes to fill that out and send it back. That would be great. So I am really pleased to introduce our speaker this morning, Dr. Liz Kessler. Dr. Kessler is a genitourinary oncologist who cares for patients at the University of Colorado Cancer Center. Her research interests center on improving alignment of care for older adults with cancer. She has an American Cancer Society Clinician Scientist Mentor Training Award that's piloting a care planning framework for older adults with advanced bladder cancer. She's also the CU representative to the Older Adult Oncology Panel of the National Comprehensive Cancer Network Guidelines Committee, a member of the Cancer and Aging Research Group, and associate editor of the journal Aging and Cancer. And she's going to talk to us today about delivering goal concordant care to older adults with cancer. So welcome, Liz.
Thanks so much. Good morning. Thank you for having me, Carrie, and to all the attendees. Thanks again for joining in this morning. I am going to be speaking on this topic of delivering goal concordant care to older adults with cancer. So let me see if I can get smart. Yep, we got to switch it. You guys seeing the other screen now?
Yes, it looks a little bit compressed, like we're not seeing the whole slide maybe.
This always happens, doesn't it? Let me see if I can do this.
That looks, oh, we had it there. Can you click on display settings?
Yeah.
And then.
Oh, you had it correct before? Interesting.
It was correct. Now yeah. And then maybe, there you go. We see it full screen.
Oh, great. Okay.
That's great.
Fun. That's funny. It's the opposite for me. Okay, well, we're good. So thanks again. I don't really have any disclosures related to this particular talk other than, as mentioned, I do get to represent our institution on the Senior Adult Oncology panel. These are some of the objectives that we'll hopefully focus on for today's talk. And we'll jump in and feel free to send messages through the chat, and Carrie and I'll kind of work on answering those as they come along. But just thinking about a patient that might come into the GU clinic, you know, I'm a genitourinary oncologist, and oftentimes I'm seeing patients that have been referred from multiple different clinics. But this gentleman is an 81-year-old gentleman, a history of atrial fibrillation, coronary artery disease, chronic obstructive pulmonary disease, and peripheral neuropathy. And he presents to his primary care clinic with a single episode of gross hematuria. And at that workup was noted to have also lost about 10 pounds in the last 6 months. And so that primary care team ordered additional testing, which included a CT IVP, which revealed a bladder wall mass as well as enlarged pelvic lymph nodes, and a lytic lesion in the posterior ileum. As we learn a little bit more about him, there's no other significant surgical history. He continues to smoke. He takes about 8 medications, and he sees his primary care physician twice a year and his cardiologist once in a while, so not really on a regular basis. He does live alone, does still get out and enjoy golfing, has some eyesight changes that make it difficult to see while driving in the dark, but otherwise is able to drive regularly and take care of most of his ADLs, IADLs. And he has 2 children who live locally that he speaks with, not on a regular basis, but is in touch with. So traditionally, we usually think about taking care of older people that may have a diagnosis of cancer in kind of 2 spectrums. We've thought about, here's how we take care of bladder cancer, and then here's how we treat older patients. And today we'll talk on a way to try to maybe combine both, or think about combining both. Similarly, trying to get out of a little bit of this dichotomy perspective. In cancer care, there's oftentimes a representation of trying to choose longevity, thinking about a common oncologic endpoint. Are we helping people live longer? And then thinking that that's juxtaposed with this quality of life trade-off, right? So an alternative endpoint that measures the symptom burden or physical health of patients. And that those might not be the only 2 endpoints that we need to be thinking about when we're talking about a care plan with folks. Some patients also might accept worsened physical health with the understanding that maybe then they felt a little bit more agency or an active role in their decision-making process. And others may experience extended longevity with preserved or improved quality of life, whether that's due to anti-cancer therapy or some other intervention. So it's not always that you get one or the other. And I think that we can talk a little bit about how to come up with a pathway that maybe threads the needle here. And that's really thinking about this broader concept of the delivery of goal concordant care. So this has been recognized as a priority of the National Academy of Medicine, other expert Delphi consensus panels, and has been thought of as an outcome that defines kind of successful advanced care planning. And I would just say that as we think about how it applies to so much of medical care, it really is the holy grail in a way of what we would hope to achieve. Because at least in the way that I would think about it for today's discussion, in thinking about goal concordant care, we're talking about care that aligns with the patient's priorities and values, care that also accounts for their physical and emotional health, right? So we're not going to ignore the fact that somebody might have end-stage renal disease when we're coming up with their care plan. And then this care is decided upon together. So it really does create an environment where information is exchanged between patients and their caregivers or community, as well as the healthcare team. We'll also talk about a few other definitions just to make sure that as I speak about certain terms, we're all using the same language this morning. So we've talked about these goal concordant care. Goals of care is another term that's sometimes used. And this, in my perspective today, talks about the values, priorities of this person, what makes them who they are. And then those can sometimes be applied in the clinical setting to help define the aims of medical care that are informed by those underlying values and priorities in a particular clinical context. Another thing that's oftentimes brought up is this advanced care planning. So advanced care planning is more of a process that can support adults at any point in time in their health to talk about how they might approach decisions related to future medical care. And so the goal of advanced care planning is to try to help ensure that people receive medical care consistent with their values, goals, and preferences, but these discussions can occur at any point in time. And then goals of treatment is another term that really can kind of describe what the goals of that particular treatment course might be, whether this is curative, rehabilitative, palliative, life prolonging. There are different ways to talk about what this treatment is really aimed to do or the goal of it. This is a model put forth by Tolsky and colleagues, and I've adapted it a little bit. But as we look here, this is talking about how clinician and patient communication can improve the patient and caregiver experience and subsequently enabled shared decision-making and mediates the delivery of goal concordant care. And so there is a reliance on this overall communication component to how people might make decisions in this setting. And especially applicable to this group, and something that I think a lot about is, what's unique about an older patient population, right? Are these a unique and separate population, or do we think of them as part of all patients? And I think many would argue that there are other things that might need to be considered uniquely in the care of taking care of people who are older. And that might be functional status, the fact that they're more likely to have comorbidities, the understanding that organ function just inherently changes as folks get older, and how this then interfaces with their cancer diagnosis, the cancer characteristics and biology, treatment options, treatment toxicity. And so when we think about older cancer patients, this really is a population that's growing. We're aware that the population globally of older people is rising, and that cancer is a condition that primarily affects older people. And so this is a very commonly referenced graph. It refers to the silver tsunami in a way, but you can see here these trajectories, and that the people who are in the 75 to 84 or 85 and older categories, so some of the older patients, are really going to be the group that grows the largest in these coming years. So why this population is unique? I would say that if we look at this slide, there's a number of bullet points here, and that really the answer is all of the above. These patients may have limited life expectancy, higher number of comorbid conditions, this potential for organ dysfunction, more risk of impaired cognition, and this limited functional reserve. And these might all play a role as we're thinking about cancer care for older patients. The majority of observational studies have found that cancer patients with increased comorbidities have poorer survival compared to those without comorbidity, and that the impact of these comorbid conditions really kind of depends on the lethality of the cancer itself, right? So what the cancer's potential risk to that person's longevity is compared to all these other conditions is quite important. But we know that the majority of Medicare beneficiaries have multiple health conditions, and that nearly a quarter of them have 4 or more conditions. So this kind of leads a little bit to this concept of comorbidity versus multimorbidity, right? And clinically, cancer has really oftentimes been considered an index condition, and these other diseases have been approached as comorbidities, right? So cancer's at the center, and then everything else revolves around the cancer. But this more recent concept of multimorbidity has been used to reflect a model which shows, that many diseases and treatments might impact each other, and that there's this interaction that could be positive or negative that affects the individual's health, and can kind of lead to this overlap of how their care is given. And I think that depending on the cancer situation, there are various perspectives where some people will still say, okay, this is the index condition, but that it's also quite important to think of the multimorbid perspective when we're certainly, at least in the GU clinic, seeing patients that may have prostate cancer that's not that life limiting, but could impact their overall health over the course of a number of years. I do think that bladder cancer oftentimes can be an index condition, but it really depends. So in this study, this was a group of men who had unfavorable risk prostate cancer. And these men were treated with either radiation therapy plus androgen therapy or radiation therapy alone. And the overall study showed no difference in the clinical outcomes. However, in this post-randomization hypothesis generating analysis, there was a suggestion that the men with moderate or severe comorbidity had no benefit from the combination therapy. And so here what you can see is that the none or minimal comorbidity had a hazard ratio of 1.51 for RT alone. So that would say that, that really the radiation therapy was a lesser treatment for them in terms of their cancer control. But if you had moderate or severe comorbidity, and this was using the adult comorbidity evaluation, then, perhaps there was harm by giving combined treatment in that group. So, definitely something to think about. We also know that, patients that have geriatric events in the hospital post-operatively, and in this study, these were defined as delirium, dehydration, falls, fractures, pressure ulcers. These events have been linked to complications, longer hospitalizations, increased risk of inpatient mortality. And, in this group, you could see that patients who had a lower comorbidity score, which was in blue, versus higher in gray, had very different geriatric events profiles while hospitalized for surgeries related to a kidney cancer, a stomach cancer, pancreatic cancer, etc. So the comorbidities really are playing a role in how these patients may tolerate and even respond to biologically their cancer treatments, whether those be medications, radiation, or surgery. So if we're thinking about how we apply this information, as clinicians, we oftentimes want to take an evidence-based approach. So we take what's the evidence base, where are the trials, and we try to apply that in the clinic, as well as adapting some of our own clinical expertise. I've been doing this for so many years, or I've seen this many patients, or I've devoted my life's work to these things. Those are the perspectives we bring, but cancer care itself is incredibly complex. Patients meet with multiple clinicians. This is a really busy slide, but it just shows some of the decision-making that goes into treatment modalities for people who have advanced lung cancer with a particular mutation. And so, the patients themselves go through a ton of visits, and, we then learn about their biology of their tumor, but we're then left with a ton of these decisions too. And this science continues to evolve really rapidly. And it means that more and more data and more need to understand and synthesize data are packed into the visits with patients. So if we think about the percent of adults with cancer who enroll on clinical trials, if we look at these numbers, just mentally come up with an answer. I'll say that of the 1.7 million or so people diagnosed with cancer each year, about 3% of them enroll on a clinical research study. So is this data helpful? And here what you can see is the results from the FDA approved cancer agents. So these would be drugs that received approval by the FDA to help treat patients who have a cancer in the years 2005 to 2015. And they looked then at, what were the makeup of the clinical trial participants for those drug studies compared with what they were seeing in the SEER database for the year 2013. And you can see that people who are under age 65 are overrepresented, so that most of these studies are over enrolling patients who are younger and may not fully represent the folks that we're really seeing in clinic. And we then have to adapt our clinical decision making to hope that they are going to represent the older patients that we usually are seeing in the clinic. But I would say that that's oftentimes not the case because of many of these things that we've talked about that make an older patient population unique. And again, quite a busy slide here, but as you can also see in this group up here that's either less than age 65, greater than age 65 or greater than age 75. And again, this is a whole list of drugs that were approved. There's a really, really low percentage of patients who are in the older patient population and represented in those studies. In some of those it's 12%, 20%, 6%. And these are drugs to treat like AML and other diseases that very clearly affect older people. Again, thinking about how real world participants or real world people and patients versus trial patients differ, these are other data that show some differences. And there have been a number of hypotheses for why this might be. Are the exclusion criteria for these studies too complex? Is there a component of thinking about the time commitment, monetary commitment, distance to care that we need to think about, right? Not everybody lives down the street from an academic medical center that's participating in research. Sometimes there's a lack of awareness, toxicity concerns. These trials are quite complex. Patients need to come back and forth for different blood draws or biopsies. And there's a push then to think that maybe we should consider creating these in more of a pragmatic format. COVID itself has really, I think, expanded some of our abilities to have more and more folks participate in research, because now many research studies had allowed us to even do like telehealth visits for research, or to allow patients that are on a standard of care arm of a study just really getting checked in on for symptoms to see their local physician, and then to have that local physician bring information to the research team so that patients can sometimes receive care a little bit closer to home or with people that they're familiar with and not have to rely on trying to overcome some of these barriers. But this is certainly something that the FDA is aware of, and that many in the cancer community are aware of, and that the trial design is not really inclusive for many patient populations. And thinking a little bit about this, lack of awareness or some of the other barriers, I do think that there's, definitely evidence on the population level that that many patients, as they get older, receive care that may be different from what the guideline recommended treatments would be. And so we did some preliminary analysis with the SEER Medicare database and found that 15% of older adults with advanced bladder cancer received the standardized first-line chemotherapy, and 60% did not receive any chemotherapy. In this NCDB analysis, which is the graph that's represented here, you can also see that as age increases, the group that did not receive any treatment, which is in the white shaded portion, increases. Patients that received surgery, which was the kind of standardized care for this patient population, really declined as the age increased. And it's unclear at this point in time if that, maybe these data represent decisions that are completely appropriate, meaning that they really did kind of take into account what the patient's values and priorities were. They looked at the health, both the physical and mental health of the patient. They came to a shared decision, but there is some concern that there might be a component of ageism or a desire to avoid overtreatment that could be at play. And that's where really trying to increase the evidence base for, how we make these decisions is an area of focus of multiple organizations. And there is a push to come up with standardized tools that could assess a patient's risk of decline while undergoing anti-cancer therapy. And so you all are likely way more aware than I am of components of a geriatric assessment. And I know that, in different geriatric specialty communities, this is looked at slightly differently, but most all of us can agree that, thinking about these various categories of health can help us understand the global health of an older person. And that this assessment or screening or an understanding and evaluation of somebody's geriatric health is, really trying to understand who's fully fit, who has a lot of, spring or reserve there, so that if there were additional stressors, which are these red circular balls on this figure, that they could bounce back after that or feel even very little impact, versus patients that are quite vulnerable or frail to where, just even adding some stressors is going to not only make it difficult for them to adapt, but could then create additional harm. And so this is really thinking about increasing awareness of some of these concepts of frailty and the different kind of risk assessments that exist in medical oncology, surgical oncology, many other populations. So the geriatric assessment really evaluates the functional and social status in addition to other medical issues. Trials have found that in older patients with a cancer diagnosis, it identifies problems that are not routinely found, and that interventions that are based off of a geriatric assessment or a geriatric screen have led to improved quality of life, the ability for patients to maintain or improve function while on cancer care, and that the survival of patients on cancer care can be unchanged with a toxicity trade-off, meaning that there might be less toxicity or similar toxicity amongst the fit, vulnerable, and frail groups, rather than seeing the toxicity rise in the more vulnerable patients. So the toxicity can stay pretty steady, as well as some of the cancer treatment outcomes. So in coming back to our patient, as we talk to him more about his bladder cancer and learn more about him as a person, he shares that his interest in evaluation and workup and treatment of his cancer, so he wants to understand more about this. he really says, as you're thinking through this, these are the things that I prioritize or that I really would want to include in my day-to-day, even if I was on treatment, trying to golf as much as I can. If I can't golf, I don't want to do anything. And then he says, just do whatever you have to do to get rid of my cancer, which we hear a lot and have to kind of delve through, well, what does this mean? Whatever we have to do, and what does it mean for this person or that we're talking with? So sometimes there's a screening tool that clinicians can use in the oncologic clinic so that we don't have to undergo a really large geriatric assessment, but this can identify patients that may have relevant geriatric impairments that would require a full comprehensive assessment. And the G8 is one such tool. It's been shown to independently predict mortality regardless of treatment in some malignancies. It's mainly used to try to predict for frailty. And so it has a cutoff score of 14, where patients that have a higher score have less risk, and those that have a very low score are heavily impaired. And this tool takes just minutes to get in the clinic. It is patient reported, although we are working on piloting this. It's clinician collected, and we're working on piloting this as a patient reported measure. There's also other tools in oncology that help assess what the risk of a higher grade toxicity while on chemotherapy might be. And this is just a way to maybe try to assign a number or a graphical representation to either clinicians or patients so that they understand, what these risks might be and what the trade-offs could be. If you see this toxicity, you might then have a higher likelihood of being in the hospital, and then bringing that conversation into the discussion about care. So the future of geriatric oncology, I think that to date, there's been a lot of work showing that this assessment is feasible, that it may, influence treatment decisions, but now we're really trying to understand more about how does it influence outcomes? And then from my perspective, does this inform goal concordant care? And really, when we think about goal concordant care as an outcome, there's some discussion about how do we measure this, right? So there's a number of challenges here that are theoretical, methodological, and logistical. But currently, most of the measurements of goal concordant care are on communication quality, right? We remember back to that conceptual model where communication was a core to this. And so many times the delivery of goal concordant care is that the patients can report on, yes, I felt like I had the chance to discuss things. My clinician was a good communicator. I felt like I was heard. A lot of times these outcomes are also comparing prospective documented patient preferences with what actually occurs. So oftentimes this is occurring later in life, where people might say, this patient expressed a wish to die at home. They did die at home, so that was in concordance with what their goals were. And very rarely is looking at the delivery of goal concordant care earlier on in this spectrum. Communication does play a large role in this. We know that communication is important just in that it should occur. When it occurs is important, and that the quality of it is quite important, right? So patient-centered care in cancer care is very communication heavy, but we also know that clinicians' skills at communicating are really variable, right? So that this graph, looking at some participants in a residency program, showed that the patient's rating of their physician's communication skills and the physician's rating of their own skills were all over the place, right? So sometimes we're inherently good communicators, inherently poor communicators can learn to be better communicators, but how this interfaces with our patients in those interactions is really somewhat random at times. So I do think that there's a role for teaching people to be better communicators, but it's hard to hang all of the interventions on communication. We did some pilot work with some of our patients who had advanced bladder cancer and their caregivers, and really wanted to explore, what older people facing cancer might want to do in terms of communication preferences. There have been many bodies of literature that have demonstrated the desire of patients to participate in their cancer care, but we didn't know if older folks would have slightly different preferences. Some literature had suggested that they might want more of a paternalistic relationship. It might be less apt to disagree. And what we learned here was that there was really some significance in key phrasing, that the patients and their caregivers really did want clear expectation setting about not just what their cancer was and the prognosis, but also like, if you start chemotherapy, it's likely that your physical function is going to decline and that it could be really hard to build it back up, things like this. And that there were some assumptions and not things that they always felt comfortable bringing up, but that they oftentimes wanted to be able to reevaluate things along the process. So in thinking about these communication tools, in this intervention, these researchers created an entire program around trying to improve the delivery of goal concordant care. So they created a conversation guide for the clinicians, patient material to be handed out. They had training sessions for clinicians on communications. The system then screened the electronic medical record for patients that could be eligible, reminded the clinicians, hey, this is somebody that you should talk to about their serious illness. And then there was also a documentation template in the EMR so that there could be, more ability for other folks to see what was documented, as well as resources for patients and their families. And so 91 clinicians were enrolled in this, some, about half in the intervention, half in the control, as well as many patients. And the results here, showed that of the participants that received the intervention compared to the control, there was a massive increase here in those that had discussions of their values and goals, as well as discussions of their prognosis. So, really the intervention itself was able to increase the communication of these factors. One of the issues, though, is like how that then leads to the delivery of goal concordant care. But we can see then that by training folks and providing the right resources to them, that we can increase the ability for these conversations to occur. There are other guides that people can use. So these are two examples of either the serious illness conversation guide, where it really just gives some prompts, right? I wish we were not in this situation. I'm worried about these things occurring. The remap framework from Vital Talk, where this can occur later along the lines, or when something really is shifting or changing, where you can reframe the situation. And these are things that we're using to teach our oncology learners, so that we all have at least some basic core communication skills as we're talking to people who have serious or advanced illnesses. And even with these trainings and with the understanding that these really can improve things, there's still a lot of evidence out there that unfortunately these conversations are infrequently occurring. They're oftentimes occurring later on into somebody's diagnosis. They may be really limited, and they're hard, right? And so they might occur in these high stress situations. In this work by Dr. Temmel's group, what they were looking at was in the pie graph here, how the concordance was between the patients in their care team in terms of, those that thought that their care was curative, non-curative, or that the patient thought curative and the oncologist thought non-curative. And most of the time there was concordance, but there's still a lot of pie graph in that orange and yellow where there was some discordance in at least 20% of the folks that participated in this. So even patients that were educated or told about their prognosis and their treatment goals, still 1 in 5 of them had a different perception of this. And I think that also trying to rely on surrogates to help make these decisions can be difficult too. So that even sometimes when the surrogates say, this is what my loved one would want, there are times that even in half cases in this particular study, the patients may receive a medical treatment that was discordant from what folks had shared as being their values and priorities. Oftentimes in this, it was more of a life-sustaining treatment rather than like a feeding tube being placed in terms of a discordant medical treatment, but still there was a surprising amount of discordance there. So when we're trying to methodologically apply this measurement of goal concordant care and say, okay, we understand that this is something that we could do better at, and then how do we measure if we're improving? There have been a few studies designed to look at this, and one of those studies is this life priority study, which is where they surveyed people who had a life-limiting diagnosis, and they were randomized to basically have these communication conversations about their cancer, and then they were asked this survey along the way, and their primary endpoint was to see if they could improve this delivery of goal concordant care and improve peacefulness. And this was a follow-up to that communication conversation guide, where you could see that there was an increase in the number of value-based discussions and an increase in the number of communication episodes. So these patients were definitely having more discussions about this, but as they ranked these values and wanted to kind of determine the extent to which patients receive care that's consistent with their top priorities, they did not see any statistically significant differences between the control groups and the intervention groups. And what they really kind of understood here was that many things changed throughout time. And that if there was something that was really at the top of the list at one point in time, it might go further down later. And that also there could be other correlates that we weren't measuring, right? And so understanding, how to have somebody be physically comfortable, but maybe not be able to be pain-free, right? How do we thread the needle there, and how do we measure that for people? Other work has also focused on, trying to document the baseline measure of patient goals here, and to try to kind of classify these a little bit. And this is a little of kind of the care planning or the what if. So, saying that you've got this documented advanced care planning guide, and then if somebody who's prioritizing comfort and avoiding burdensome treatments over here on the left, that person may have, been in the ICU for one particular reason, but that person is going to receive palliative care in the ICU and die comfortably in the ICU surrounded by family. If somebody, has a particular life event that they're aiming for, whether that be a child's wedding or something else is in the blue column, then that person may opt to receive advanced cancer treatment, chemotherapy, radiation. They may be bedbound and more dependent, but they would have made it to that life event in some way. And so it's really trying to, understand how we're going to account for these goals and priorities to better classify them. So the logistical challenges are also that the existing tools and measures that we have out there are not implemented well. And how do we also measure this across a chronic and changing illness? So this graph here represents an ASCO, that's the American Society of Clinical Oncology survey, that was sent out to all members, but there were about 1,200 respondents. And of those respondents, only about half of them were aware of the geriatric oncology guidelines. And they were asked about barriers to performing geriatric assessments or screening. And you can see that of those that were aware of the guidelines, the blue bars, the barriers are slightly different than those that were unaware. But time and support staff are huge. And I think we that practice in the clinic each day understand that a lot of people are working really hard, and that more support would always be welcomed. And that the people who were unaware of the guidelines, really were unaware of the tools, They weren't sure which tool to use. And so really trying to get the word out there to folks and really simplify what is available and how people could use it, I think is a goal of the geriatric oncology community. My own research work is piloting this care planning framework. So this is really aimed at creating a responsive system of care delivery. So we're trying to design something that could be implemented and disseminated to multiple other clinical environments in the future, including other patient populations. And this is funded through the ACS. We're working with patients who have advanced bladder cancer because it seems to be a group that really does represent a lot of some of these challenges and concerns of older adults with cancer. And so patients will have a new diagnosis of a cancer. They'll meet with the oncologist. If they enroll on the study, they'll then have 2 visits with an ABC 123 advanced practice provider. And at the first visit, we'll understand more about measured physical function. So really trying to see how these older folks move around using validated tools, as well as do a measure of chemotherapy toxicity using, again, an existing validated tool. The oncologist and the APP will debrief and say, okay, this is what, I learned this person has some vulnerability in their mobility, or their risk of chemotherapy toxicity on the calculator was 93%. And then the APP will also have a second visit in which a guided goals of care discussion occurs. So there will be a framework that's followed, a template that's used to document that in their chart, and that will be shared with the patient as well as the care team. And then the oncologist will follow back up with the patient to kind of come up with the final care plan, whether that be chemotherapy, unmodified, modified chemotherapy, supportive care alone. And hopefully then that will be informed by the patient's values and priorities, the understanding or a better objective understanding of their health, and then a shared discussion can occur. So again, when we come back to this concept of goal concordant care, we can think through this framework using tools that are already in existence, so not coming up with a brand new, thing, but maybe doing a better job of trying to implement that in a way that every patient has these discussions or assessments, that hopefully then would increase the alignment of that delivery of goal concordant care. How we measure this is, I think, going to be a little bit more tricky. So we are going to use mixed methods to try to understand a little bit more about where there might be key signals to how we best measure this alignment and perceived goals of care. So the first measure is going to be this perceived goals of treatment. Patients will say, I think my treatment's curative. The oncologist will say, I think this treatment's curative, that sort of thing. That shouldn't really happen in this population because all of them are likely facing a life-limiting illness. But we will measure this concordance. And then we'll better understand what this decision-making process was like for the patients. Did they get a sense that their values and priorities were taken into account with the decisions? So we'll use some validative quantitative surveys as well as guided qualitative interviews to understand how that process went, so that we can try to come up with a better way to measure this care alignment for future studies. So if we think about our patient in the clinic, his function was measured in the clinic. He had a chemotherapy risk calculation. He comes back for this second visit and brings his children to really talk through more about how he generally wants to approach his care. This is discussed and documented in his chart. And after a discussion with his oncologist, he pursues slightly modified chemotherapy. So, when we think about the future state, we can think about this being a goal of cancer care for each person based on a mutually set goal that incorporates the whole person, right? We're going to stage the cancer because understanding the cancer and its biology can inform the treatment options and decisions there. We're going to stage this aged person, understanding, where they are in the physiologic age rather than chronologic age spectrum. We'll have and document a discussion of serious illness with the patient and whoever else they want to be a participant in that, and then communicate this treatment plan together. So that's the hoped future state, and we can work on the science to better measure if we're achieving that. Thanks so much.
Thank you, Liz. That was fantastic. Really appreciate your presentation. Anyone have questions? Feel free to go ahead and put those in the chat box or the Q&A. We've got time for questions. We have a quiet group today. Most people are typing.
Yeah, I will say that there was just a recent update. The International Society of Geriatric Oncology held their meeting just in the last week or two. And I think that of that, from that meeting, there's just more and more interest in how do we, have these conversations with folks and use some data to help inform these decisions, right? And so I think that in some of the work that Dr. Matlock's done and others on the campus, we can see these trade-off discussions, and that's coming out in the geriatric literature as well. How do we talk to people about what to expect on chemotherapy and what some of those pros and cons might be, even bringing in concepts like life space and some of these other issues that I know that many folks are interested in.
Mm-hmm. Yeah. So question coming in, comment, this is great. Very hard for us to know all the nuances of oncologic care, but would be helpful for us to be better informed when we advise patients as geriatricians. Any suggestions for us?
Yeah, I would say that it probably is just like in the discussions between patients and their care team. The care team itself probably needs to have good communication, right? And so I do think that if, because cancer care is, as I mentioned, changing so often, it's hard to even say like, oh, well, this is how patients with lung cancer fared, 2 years ago, 3 years ago. That might be different now due to some of the new agents. And so it probably is worthwhile to just reach out to treating oncologists or consultants to understand a little bit more about that. I know that there's many times that I reach out to people to understand more about somebody's overall health, because I don't want to miss something that's not picked up in our usual just, ECOG performance status assessment or something else where, where a care plan could really be well influenced by the input from their geriatric team. So it's probably best a discussion. There are, I think that the SEER stat facts just that kind of talk about like survival or other pieces there can sometimes be helpful. But it may just be worth a communication between the docs or providers.
Thank you. Any other questions from participants? All right. Well, we'll end a few minutes early then, give people a couple extra minutes in their morning. Liz, thank you again so much for presenting. Really appreciate it. It was a great update, and yeah, look forward to hearing future work.
Thanks, Dr. Hildreth. All right.
Thanks. Bye-bye.